for approving this workshop and thank all of you for being here in this late hour. Actually, my burden was lessened by Dr. Andrade's presentation today morning, which dealt very in detail about compliance. And I think this is an ideal number for a workshop. But unfortunately, we are hardly pressed with time. So I will be as precise as possible, and we have to conclude the session in time because the general body meeting is due to start. Compliance is now recognized as a major problem in treating almost all medical conditions. We initially thought it's only a problem with psychiatry, but it is proven to be not the case. This is title of an editorial of IJP. You can take the horse to water, but horse should decide whether to drink or not. This is a major problem in treating psychiatric illnesses. First of all, the problem starts with what to call this problem. It was Shakespeare who told what is in a name, but we know now that there are a lot of things in a name. For example, the metaphor in the editorial may be definitely objected by any of the consumers of mental health, even though it is a metaphor. You cannot compare a caretaker-client relationship with such a metaphor. So many terms were introduced. Compliance was the first term which was even now commonly used, but the preferred term now is adherence because of the issues of naming. I am not going into the details for want of time. I will be using both these terms interchangeably. Let us ask this question. I will be asking many questions for which there is no one correct answer. Probably there are a lot of answers for each question and each one correct in different context. So just think of this. If a patient takes dash percentage of prescribed medications, I will consider he or she as compliant or adherent to the medication. Which one do you agree? 100%, 80%, 60%, 40%? 100%. Let us see. See, if you plot the adherence on prescribed medication, then number of people, there is no zero as adherence. On the other side, there is no 100%. They are almost nil. It's like a normal curve. Most of the people are in between. So, and there is no satisfactory compliance range on which everyone agree. No one agrees on a particular range. Partial compliance is very common. Almost all the researchers take the criteria of 80% or some 70% as adequate compliance. And next question, how many percentage of outpatient clients are adherent according to this criteria? 30%. Again, the answer may vary depending upon the situation, the clinic, the type of clients you are attending. These may vary very widely, and the studies show that they vary very widely. Let us see what the literature says. See, many times the percentage depends upon how and who is assessing and what is the method used. If the patients are to be trusted, in one study it is 67.5%, and if you trust the pill count method, it's only 10.3 for the same population. Another study which uses MEMS. I will just briefly tell what it is. New method in finding the compliance is using an electronic monitoring in the cap. When you open and take a pill out, it will be recorded. So using this method, the one population, it was found that 38.1 is the percentage of compliance, but the clinician in the same assessment for the same patient was 94.7%. So depends upon who measure and how it is measured. And if you look at the various other conditions like weight reduction, it's a healthy behavior. Exercise, flossing, dental flossing, advised by the dentist. The rate of non-compliance is very high. And schizophrenia, several studies show it's around the 80 to 90%. This study is particularly 91%. So, point number 1 is non-compliance is pervasive, and the research tells us so. And is it a problem with some minor conditions like weight reduction, exercise, or something like that? No. Let us see. If you take type 2 diabetes over 1 year, if the person is taking sulfonylurea, it was found to be 31%. This particular studies I have quoted below. I am not going to the details. Metformin, the same group, it was found to be 34%, and if they are taking both, only 13%. 25% of patients treated for hypertension don't follow their treatment plans sufficiently to reach their target BP level. 15% of hospital readmission for heart failure were secondary to underutilization of prescribed medication. Only 28% of asthma patients use preventive medication prescribed to them. And again, there was a relationship between the duration or chronicity of the illness and the compliance. These are the percentage of compliance in various chronic conditions in one study. Study is quoted below. So, point number 2 is non-compliance is pervasive regardless of the patient population. It's very pervasive. Let us see whether the seriousness of the condition, how much it is influencing the compliance. Just think of this. Compliance, you have to tell whether it is true or false. Compliance is not a serious problem in life-threatening medical conditions if the patient is informed about the seriousness of the condition, like renal transplant or myocardial infarction. What do you say? Yes or no? Compliance is not a serious problem in life-threatening medical conditions if the patient is informed about the seriousness of this condition. For example, a child. If the seriousness of the condition is informed, the compliance is not a problem. That's the statement. True or false? False. Let us see. Patients who choose to undergo renal transplant, 50% do not adequately follow their medication regime to prevent rejection. 25% regularly miss the dose of the prescribed medication. Patients with glaucoma, 58% of those who were told that failure to use their medication would result in blindness were non-compliant. 42% of patients who had already lost one eye after they failed to comply with their medication persisted their non-compliance. HIV patients on antiretroviral treatment, 43% admitted not taking medications as prescribed. 6% of them never refilled their prescription. You should remember that these medicines are given free of cost. Even then, 6% of them don't even refill their medication. So, point number 3 is non-compliance is pervasive even when the stakes are high. Again, consider this statement, all these statements, whether think whether they are true or false. Psychoeducation will substantially improve the compliance in our patients. True or false? True. Let us see. Non-compliance is strongly related to medication side effects.
Yes. No. Sometimes. Yes. No. Sometimes.
Non-compliance is strongly related to lack of insights.
Yes. Sometimes.
But research shows that all these statements are false. And another study in medical students which used prescriptions with electronic monitoring, it was found that even in medical students, the 2 weeks regime, when given BD tablets and TID tablets, they were very poor compliance. They were having very poor compliance. And they told excuses like they were busy, they were having so many other things to do, so many excuses. So point number 4 is non-compliance is pervasive even among knowledgeable patients. You may be happy with a patient regularly attending your clinics, every appointment without missing. But clinic attendance, even then, regular attendance does not assure adherence. Patient keeping more than 60% of their appointments, 40% were found to be non-compliant with medication, determined by urine metabolic assessment. Antipsychotic adherence in 61 patients who were regularly visiting their clinician. 6 consecutive visits. These are the 61 patients who made regular appointments on 6 consecutive visits. It was found that doctor assessed 95%, patient adherence according to report is 95%, 93% according to physician, and by electronic monitoring only 43%. So point number 5 is non-compliance is pervasive whether the clinician detects it or not. So I am not going to state it all again. It's all again written there. I am going to the next point. Let us go to the compliance in mental illness. Are our clients more compliant, more non-compliant or non-adherent than other chronically ill patients? More or less? How much more? Or all the same? But it's found that even though non-compliance is pervasive, our patients are more non-compliant. These are and more for antipsychotics. And it's found that 1 out of 3 pills are not taken. Patients forget medication, non-intentional non-adherence. Choose not to take medication, that is intentional non-adherence. And the compliance or adherence was found to decrease over time. 7 to 10 days after discharge, 25% of the patients were not found taking medicines. And after 1 year, it's around 50%. This is in this particular study. And we know that non or partial adherence in schizophrenia is very common. 2/3, in almost every study, 2/3 don't take medications regularly. And this is a very important cause for revolving door phenomenon in schizophrenia. And as the relapses increases, the time for remission goes on increasing. This is what we know. The patient, each admission, he needs more and more duration to get better. And as the number of relapses increases, their psychosocial function also decline. And we know that there are multitude of factors involved in the therapy lapses in schizophrenia, like impaired judgment, complicated treatment regimes, substance abuse, poor social support, side effects of medications, and poor symptom control. And we have to look into what are the factors which determine this phenomenon of compliance and non-compliance. It can be reduced into or grouped into a triad of patient-related, medication-related, and doctor-patient-related factors. As we all know, I'm not going into the details. And most important and modifiable factor which we can make a change is doctor-patient relationship. In communication skills, the disparity between the beliefs of the patient and the doctor, and the most important, motivating, giving positive reinforcement to the patient or client. And already mentioned the motivation, the circle, the Prochaska's model we have to keep in mind. The stages of a behavioral change, whether it is drug, medicine taking behavior, compliance behavior, or any other behavior, it goes through all these stages. And there are a lot of steps in improving the compliance, like reducing polypharmacy, simplifying treatment regimes, providing psychoeducation, involving patient in decision making. And one thing we can easily try is long-acting injectable preparations. And now we have an array of injectable preparation, and almost all the guidelines suggest the serious consideration of an injectable long-acting preparation when the client is non-compliant. And definitely our patients can do better, and statistics show that it is underutilized. These long-acting injectable preparations are underutilized in our country. If you look at the global picture, many countries, up to 50% of chronic patients are on depot preparations, especially in UK and other European countries. US, the depot preparations usage is less. And what is the advantage of using depot preparations? Covered non-compliance or non-adherence is not a problem. Only overt non-compliance is the problem, which we can know and we can tackle. And when an intervention, when a dosage is missed, intervention can be planned, identified. Sometimes there may be covert type of resistance which becomes evident when you use depot preparation. You can handle it. But the caveat is, changing the oral to depot need not increase compliance. You have to have all other measures, some other measures also, which I will mention briefly. As in any treatment, chronic treatment, therapeutic alliance that should be strengthened, it should be based on trust, a working relationship, taking the patient into confidence, sharing beliefs, discussions, negotiations, and to some extent persuasion and involvement of the family. And we have to differentiate between attitude and behavior in compliance. Patient may be adherent to the medication and have a favorable attitude. That group of clients or patients have most compliance. They have positive attitude and they take medicines. There are clients or patients who take medicines, accept treatment, but they are against, I'm talking about the second column. They are against treatment but take medications. Maybe because family wants to take the medicine. They don't like medicines, their attitude is against, but they take. There are patients who accept treatment. They say they want treatment, but they don't take treatment because they forget. And least compliant group who are against treatment and doesn't take medication. So we can target these two groups to improve compliance always. For example, if a client is having a positive attitude and negative adherence, this is a target group for which you can always try depot. He always forgets. Only when symptom comes and relapses comes, he is compliant. The other person also, the problem is he is taking medicine since the family want him to take, or somebody is taking care of the medication part. Suppose the family is no more able to attend, the father who was giving the medicine is sick, then he will have a relapse. So this group of patients also have to consider depot. On starting a long-acting depot preparation, we have to enhance therapeutic alliance. If you go into the net, vital videos by one of the pharmaceutical companies who is giving the depot preparations, they have a very good video on these motivation methods, how to enhance compliance, leap and gain. I am not going into the details, given beautifully in the video. Vital videos, if you search, you can find it. They speak about the leap and gain methods also. I am going to the practical aspects. On prescribing depot medications, it is advised to give a test dose, smallest dose, IM, and wait for 1 week or 2 weeks. And while putting the patient on depot for long term, use the longest possible interval recommended. That will be the greatest benefit. And adjust doses only after adequate periods of assessment. Because many times when you start a depot, the therapeutic blood level will be reached after 3 weeks or 2 weeks. And it will take longer periods if you are giving weekly or bi-weekly injections. After a few months only the therapeutic level, peak level will be reached. So frequent increase in dose will cause a toxicity later. This is the list of long-acting injectable preparations. Few of them are not available in our country. Olanzapine palmoate. Recommended doses, intervals, and comments. I am not going into details. If possible, I will hand over the slides. So the new intervention of long-acting SGS, second generation antipsychotics, have made this method of treatment very much useful. Risperidone, paliperidone, and olanzapine long-acting preparations are there now, even though they are not, all of them are not available here. This is the one molecule which is available in India, but as you know, cost factor counts. And long-acting risperidone aqueous suspension is in a polymer form. Few things we have to remember while using this product. One is only a small quantity is released in first 24 hours. Almost nil is released for 3 weeks. So you have to put on oral risperidone till the action of the injectable preparation comes into effect. And recommended interval is 2 weeks. And it's found that, like other injectable preparations, long-acting risperidone also is effective in schizophrenia, psychotic symptoms, the SPANS score, the clinical verbal impression scale, GAF scale, everything. Olanzapine palmoate depot is also available. It's also in the market, not in India. Again, cost factor. And one important thing, even though this is not in the market now, one important thing to remember is one side effect. Post-injection delirium sedation syndrome with olanzapine injection, because of the extravasation, the damage to blood vessels which can occur, causing sudden absorption of olanzapine into the blood circulation, causing toxicity symptoms. So it is mandatory to keep the patient for 3 hours in a facility where acute emergency management can be done, and the patient should be reachable to the center within 24 hours, for 24 hours. And if you look into the pharmacokinetic profile, the first one, the violet line, is the blood level of oral medication, second of the oral long-acting medication, and the steady blood level maintained by injectable depot preparations. So the advantage is obvious. And regarding the difference between different depot preparations, only few differences, just like any other antipsychotic. Only the adverse effect, differences in adverse effects counts. Fluanzole is having less chance of EPS, lesser chance of EPS with second generation injectable depot preparations. Flufenacin causes less weight gain. Risperidone and olanzapine also less EPS. And last but not least, the cost factor. The other injectable second generation antipsychotics are not available in the market. So maybe when the second generation injectable long-acting preparations are more economical, more of our patients will benefit. Thank you.